Week, which is a moment to focus national attention on the health inequities and disparities that uniquely impact Black mothers. Over the past couple of years in New York, there have been commissions and task forces and studies in our state whose entire purpose was to study Black maternal health care and maternal mortality in New York. And all of these were prompted by what have been alarming disparities between the maternal mortality rate among Black women versus the maternal mortality rate among white women in New York. It's a disparity in health outcomes between Black mothers and white mothers that is higher in New York than in any state in the country. Why do I mention this in the context of the New York Health Act? And the reason I do is because this is just sort of a snapshot of one of the appalling inequities in healthcare in the United States, and particularly in New York. And it's because the most powerful policy change that could really take the biggest step to make our healthcare system equitable is to pass the New York Health Act and to create a universal healthcare system, a single payer system. This is not to say that the New York Health Act would end gender discrimination in healthcare, that it would end racial bias in medicine. These are problems that demand additional policy changes as well. But making healthcare universally free at point of service would be the biggest step that we can take to make sure that Black and brown women receive the same high quality care that all New Yorkers need and deserve. And so now is the moment when we are best positioned to push for and pass the New York Health Act, because people see the urgency right now more than ever before. The devastating impact that the COVID-19 pandemic has had in New York has really exposed deadly weaknesses in our healthcare system. Even before the pandemic hit, research showed that more than half of Americans who have employer-sponsored health insurance had delayed or postponed recommended treatment for themselves or their family because of cost. That's only among Americans who have health insurance through their jobs, what is supposed to be good health insurance. If those Americans are afraid to go to the doctor because it's cost prohibitive, consider this: only about 55% of all Americans even have health insurance through their employers. So the number of Americans who live in fear of getting sick or who decline to go to the doctor when they are sick because of what our failing healthcare system, that number is even higher for those who must rely on Medicaid, and for the roughly 26 million Americans who still have no health insurance whatsoever. What COVID-19 has revealed is just how inequitable our healthcare system is, particularly through the vast difference in the pandemic's impact on people of color versus white people. This is now very well documented. I'm sure all of you are aware, but Latinx Americans, for example, have nearly 7 times the rate of COVID-19 cases compared to white people. Black Americans have the highest death rate of any demographic, being nearly twice as likely to die from COVID as white Americans are. It's a higher rate in New York. And it is not a coincidence that the highest number of deaths from COVID in our city and state are in zip codes where most of the residents are Black and brown and are low income, including some communities in my district, such as East New York. People who cannot afford preventative care and who do not have access to high quality care where they live will not receive that care. And they're then more vulnerable to not only COVID, but are more vulnerable to all kinds of preventable and treatable illness. Additionally, consider our undocumented neighbors. Undocumented New Yorkers are legally barred from getting health insurance. But in addition to the financial barriers of being uninsured, undocumented New Yorkers are often less likely to seek medical care when they need it because of draconian immigration policies that have made immigrant New Yorkers fearful. Thankfully, of course, the federal public charge rule is effectively dead, but nonetheless, people whose immigration status is precarious are still often afraid to go to the doctor. and to go to a public hospital. This is another injustice that has been exposed by the COVID crisis. Undocumented workers are essential workers. The majority of visible essential workers in New York, more broadly, are people of color. Many of the people who've been tasked with holding up the care economy through their jobs cannot receive quality care themselves due to cost. So in this moment, people who've previously had the privilege of not thinking about our healthcare system's failures, even some legislators, have come to see it for themselves during this crisis. And people have become more aware of the ways in which all of us rely on one another and the ways in which we are interconnected. And the good news is that this is not a secret. The injustices in our healthcare system are now on full display, and people are demanding that it be transformed. And more people are demanding that we pass the New York Health Act in order to do that. This year marks the first time in New York's history where we have reached a solid majority of legislators in both houses co-sponsoring and supporting the New York Health Act. We now have more than enough co-sponsors of the bill in both the state Senate and the state Assembly to pass the bill if it were to be brought to a vote. And additionally, I've often said over the past few years that one of the biggest obstacles politically to passing the New York Health Act is Governor Cuomo, who is, of course, very staunchly opposed, is closely aligned with the forces that oppose, the institutional forces, lobbyists, the healthcare industry largely, who are opposed to universal healthcare. That has always been a huge barrier. But I don't place too much hope. I'm careful to not place too much hope in the weakness of the governor in this moment. But I do think that it is it's significant that Governor Cuomo has suffered a pretty big political loss and loss of the public's trust recently. And I think that his weaknesses were on display in the state budget process, where for the first, I don't think it's a coincidence that the governor is in the position that he's in right now and is being exposed for who he is and what he's done. I don't think it's a coincidence that that is happening. And at the same time, in the state budget, we were able to raise billions of dollars in revenue and new tax revenue specifically, which hasn't been done at that scale in any of our lifetimes in New York State. So for all of those reasons, I am especially hopeful right now. There are a lot of reasons to be hopeful. Lastly, all of you who have been advocating for the New York Health Act, those of you who organized this town hall and who are publicly pushing for it, you also give me hope. Your movement and your advocacy has only grown and continues to grow. And that really is the pressure that we need, that got us to the number of co-sponsors that we have, and that is going to get the New York Health Act passed and signed into law. So I'll stop there. Thank you.
Thank you so much, Julia. We're gonna move right along to our next speaker, and then we're gonna have a brief Q&A after everyone is gone. Our next speaker is Andre Mays. He is a staff organizer for the Sheet Metal Workers Local 71 in Buffalo. Andre, take it away.
Thank you all for your time. I appreciate it very much. It's good to see so many fellow DSA members on here that are fervent and ready to get out there and take care of this. So I'll do a quick brief background. My name is Andre. I'm an organizer up in Buffalo. I started working at a company called Danforth as a non-union truck driver. They do have plumbers union and a sheet metal union there. And when I learned about the benefits and wages, I decided that's what I was going to do. So after about 2.5 years, I got into the union, and I can very adamantly say that being in the union has increased my standard of living and my quality of life very much. I mean, there's anyone who lives upstate and downstate, but there is, up in Western New York and the Finger Lakes and Central New York, there's a stigma from about 70 or 80 years of people fleeing the cities up here, and life can be very difficult, and being in a union has been an excellent way to carve out a middle class living for me. So that's just a little background so you know where I'm coming from, because I kind of want to speak from a union perspective, at least anecdotally. But back in early 2020, our union's healthcare was in crisis. At the time, we had negotiated to have our contractors pay $7.20 per hour for our healthcare, which, doing a little back of the envelope math, comes out to $57.60 per 8-hour workday per member for healthcare coverage. In 2020, this still wasn't enough to cover the ballooning costs of our private coverage. So we had to open our contract back up and have a big meeting on how we were going to cover our healthcare. The contractors weren't willing to chip in any more money, so we had to take $2 per hour out of our annuity and place that into healthcare just to keep it solvent, which pushed for an 8-hour day of work the cost of coverage to $73.60. So for comparison, the average Dane, someone from Denmark, pays about $50 per month in taxes for healthcare, just an average middle class wage. So $50 per month versus $73.60 per day. And that, we consider ourselves to be very, very lucky with our healthcare up here for that we get from the union. So that's money that we would like to use annually for raises or to go towards our annuity instead of coming out of it, or into our pensions, which, not to even to get into that, is something else that's vanishing rapidly. But all that money is getting swallowed up by healthcare cost. So when I'm speaking to union members, the question that I ask myself is, how would the New York Health Act help unions? And by creating a single payer healthcare system in New York, my union's members would have an extra $9.20 to do with as we please. That's money that we bargained for as a union that we would expect to be able to keep the majority of. And even if our contractors did claw some of it back, even saying half of it, that would leave us about $4.60, if my math is right, to place into pensions, place into our annuity, place into our paychecks. And we would no longer need to negotiate over the basic human right of healthcare. My fellow officers and I would be able to spend our negotiating clout and energy on further improving the lives of our members' standard of living elsewhere, like I said, in pensions and annuities and paychecks, or maybe even to have a little bit of that money would be nice to use to have a little bit of sway in lobbying efforts elsewhere. I work closely with local governments here to try to get pro-union legislation passed, and this is just anything that we have to negotiate over or go to government for. It's just another piece. It's time spent and energy spent that could be spent elsewhere. And I think that healthcare is a pretty bad place to have to be spending energy. It's a basic human right. A major grievance that union members have is that if they are young and single, they have they don't want to pay for the healthcare of older or sicker members, or for members who have families. The New York Health Act would create an even playing field where healthcare becomes both cheaper and easier to access, and eliminates the complaints and a lot of avoidance that people seek, because when it's free at the point of service, you just go if you have a problem. You don't think about, well, I have to schedule an appointment, I have to get a referral, I have to cover the co-pays, what are the deductibles, what are all that other stuff that you would no longer have to worry about. The Health Act would fix a few major problems that were created on the Affordable Care Act exchange market. By creating the mandate for young people to purchase private insurance, companies were able to maintain high prices, as it was law, for people to have coverage. It wound up being that a lot of young people took the annual penalty instead of getting health care, and as that forces older and sicker patients to shoulder the burden of the cost, it has an upward pressure on prices, because this is, the Affordable Care Act was not a price. It wasn't a healthcare coverage fix. It was an insurance fix. Everybody now must be insured, but it did not put any realistic downward pressure on prices. And then, as we all saw in the last few years, the GOP-led repeal of the individual mandate and opening of states to have open markets across state borders has led to more healthy people dropping off insurance rolls and employers being able to purchase skeleton plans from other states and sell those as insurance, which has a simultaneous effect of raising prices and lowering quality of care and coverage. And the only reason that my union has been able to maintain the private coverage we have is because of the size of our purchasing unit. That's, we can collectively bargain for reasonably cost to get the money from contractors, and then as a large unit, we get a better deal on healthcare. We have zero premium plans with no deductibles and low copays due to our bargaining strength. The New York Health Act would do the same for New York on a grand scale. My 600 union members would join 19 million other New Yorkers on a single government provided plan that would dramatically increase the leverage of every citizen in the state when bargaining for affordable quality health care. So, in conclusion, it's often said that healthcare is the single greatest recruitment tool for unions, but I find this view to be cynical and short-sighted. My union and our state and nation would benefit far more from being able to put that money into wages, retirement, or even, as I said before, effective political organizing for my union. Our people, be they from New Yorkers or Buffalonians or from Rochester, Syracuse, Utica, Watertown, all over the state, would do far better as a whole if healthcare was something you simply expected to be there, like the fire department when your house is ablaze or the roads that we all use to get to work. We have a long way to go as a country to catch up to the rest of the world, but I do believe that this is the first generation in a century that's no longer blindly accepting that we must do more with less to defeat the terrifying scourge of worker power and solidarity. I do believe with all my heart that my union, that both unions, the one that gave me my trade and the one that pulls our country together, would be better off if we treated healthcare as a public good and not a profit center. And with New York being the financial hub of the nation, we would be the best state to lead by example. And with the votes in both chambers of the state legislature, this really is the best time. On top of that, with COVID, all these factors coming together, this is the best time to push forward and gain the same quality of healthcare for all New Yorkers that my members get to enjoy and that the rest of the world gets to enjoy, and for a fraction of the cost. And that's why I believe that time is now for the New York Health Act. Thank you.
Thank you, Andre. We're now going to hear from Naomi Zodi, who's an assistant professor in health policy and management at the CUNY School of Public Health.
Thanks. Okay, and excited to be here with everybody and to get this kicked off. Yeah, that was a great explanation of of how the New York Health Act interacts with unions. Okay, so basically we have two kinds of inequality problems in the United States, and one of them is at the right of the screen, and it's the white plutocrat class. And the other problem is in the middle of the screen, and it's the inequality, racial wealth inequality that happens between everyday white families and everyday Black families. And we have to confront all of the inequality in order to create, an economy that actually delivers for even for segregated communities and poor and Black and brown people. The inequalities that exist, they just recreate themselves until you exert the will to stop these things. We have COVID cases by zip code, and they happen in the same places that maternal mortality is happening around the city. It just keeps happening. And we have fairly inequitable healthcare and unaffordable healthcare in the United States. So this is just above and below median household income. So even in the United States, above median, so higher income households are more likely to have not gone to the doctor within the past year due to cost than lower income people in other countries in the world. This is the United States, and we're extremely an outlier in the cost of healthcare. And over here, we're an outlier in life expectancy because we have far lower life expectancy. So the question is, what are we spending all of this money on? if we're not getting any healthier. We have fewer, here's the US here, fewer physician visits per capita, we have fewer physicians per capita, and we have more chronic conditions. How is that possible? You know, every year over year for over the past decade, the thing that has been growing the fastest is deductibles. Deductibles are too damn high. And after that, in the middle here is premium, how households' contribution to their private insurance premium, also growing year over year. And then finally, at the bottom, we have median income, which if it does grow, it's much smaller. So healthcare is becoming further and further out of reach for all households. And as healthcare is becoming more expensive over these years, it's not just households, it's also every industry in the United States that's getting taxed by this globally, like on a global scale, just wildly inefficient healthcare system. And there's so many different pieces to this administrative puzzle. And it's like all of those pieces cost money. So we have the Affordable Care Act. And, you know, when we were doing the debates, the Democratic presidential debates, we were actually having this conversation about what we should do next after the Affordable Care Act. And so basically the ACA left us at a point where if you look at, you know, compared to what they were expecting, the change in uninsured was about correct, but only because way more people wanted Medicaid than they predicted, and way fewer people wanted the private insurance. So here is the actual number of people who signed up for the ACA's private insurance policies, and this is the number of people who they projected. And this is, but you know, like, I mean, this is almost double. It was fewer than 10 million. Now we have about 8 million enrolled now, and they were projecting like 22 million. And here's the actual in Medicaid. They had to lower it because they knew not all states would end up signing up for the expansion after that Supreme Court case. So this was, given that not all states would do it, this was their prediction, and way more people wanted it. It turns out that the public healthcare expansions of the Affordable Care Act was the most successful thing, and far beyond what anybody expected. From Medicaid expansion, we have reductions in poverty, reductions in the rate of home evictions in the United States that are all very cleanly traced to the expansion of Medicaid. But with the private side, you know, it was actually cheaper for about 1 in 4 previously uninsured adults. It's cheaper to file for bankruptcy than to reach the deductible of the subsidized benchmark tier of private insurance coverage of the ACA. So it just isn't great coverage. So we were having this debate: do we do the public option or do we do single payer? That during these Democratic, you know, presidential debates. And, you know, in the 60s, when they decided to do Medicare for all seniors, they considered the concept of the public option, and they just rejected it because, number one, a commercial insurer cannot offer the same kind of benefits. Even if you take profits out of the equation, the whole point of insurance is a humongous pool of people, and private insurers have smaller pools. And secondly, it's the idea that the notion of free choice when it comes to which doctor, which therapy, which facility is fundamentally important. But the concept of free choice when it comes to the opportunity to pay more for worse coverage is not meaningful, and it's not a policy priority to protect that at all. So the problems with the public option: number one, the best case scenario is that it destabilizes the private market. People are very premium sensitive, and a lot of times they just sign up for the cheapest thing. So if the public option is in truth a high quality, low cost alternative, it will destabilize the private insurance market. What we're really seeing is that insurance companies are doing everything they can to prevent the public option from being a meaningful disruption to the market, which means to make sure the public option sucks. You know, but even if we did get it, it's still inefficient because it just adds one more piece to that expensive puzzle, which is the thing that sets the United States apart from every other country. And also, it's like still inequitable. It doesn't actually define, are we still going to have those kinds of deductibles that we saw in the Affordable Care Act, which make the concept of coverage essentially meaningless anyway? So, you know, right now, as income increases, the percentage of income that goes towards healthcare is falling. Same premiums, more income, smaller percentage, right? With the public option, let's say it was a Medicaid buy-in kind of thing, it might get a little bit cheaper, but it retains that shape. The good thing about a tax-financed, no deductible, no copay, no network system like the New York Health Act is that we get a rational basis for determining what percentage of income goes towards healthcare, and we can make it increase as your ability to contribute increases. And Yeah, I think that's the main thing. Plus, it's overall in aggregate fewer resources going to provide healthcare, even though we're getting more healthcare, simply by taking out all of that administrative expense. So it actually solves the problems in the American healthcare system. And it's all about political will. That's it. That's all it is. And right now, we have what we have is a healthcare system run by the plutocrats that doesn't serve our collective needs. And a growing realization of that fact, coupled with majorities in the Assembly and the Senate co-sponsoring. So this means if these guys are all co-sponsoring this bill, you can imagine that they're probably going to vote for it, right? So we have majorities in the Assembly and the Senate co-sponsoring this bill. So the only thing that's in between us and a rational healthcare system is political will. And it seems that we might have actually overcome that in this moment. All we have to do is bring these things to a vote and push it through. So it's a really unique moment and like very exciting.
Thanks so much, Naomi. We have one more speaker before we head into Q&A and then our breakouts. I've been saying this in the chat, but I just want to say out loud one more time. If you haven't signed in, please do so we can put you in the right breakout. There's the form. And our last speaker is Cheryl Cashin. She is the managing director at Results for Development, a nonprofit working with global health and education. And she's the co-facilitator for the healthcare committee of the Progressive East End Reformers.
Thank you, Emma, and hello, everyone. It is really heartwarming to see all of this interest and support for the New York Health Act, and a wonderful conversation so far. I wanted to just share a little bit about what we've been doing on the East End of Long Island and some of the conversations here, where I definitely feel over the last 2 years, the momentum is growing and the interest is growing in the New York Health Act. There continue to be a lot of questions. And one of them, of course, is always how we're going to pay for it. And that question continues to surprise me after what we heard that Naomi shared. It seems so obvious that there is so much waste in our system, that we put so much money into the system, we get so much little out in return. If we were just able to reorganize that money and use it more effectively, that's how you pay for it. But that means paying for it through a fair tax. And as soon as you say tax, people tend to have an aversion. And even though I think premiums, deductibles, copays, surprise bills are a tax on the sick, people tend to feel more comfortable with those words, it seems, than tax. So I want to share, I think, looking at this issue slightly differently, and I really want to acknowledge some fellow activists who have been looking at the tax money that we're already paying into the system that goes to inefficient private healthcare coverage for people covered with tax dollars. And when you see, and we'll show you a bit of the absolute magnitude of the waste of those tax dollars going to cover public servants and other government employees with private coverage, it's another way that not only can we see how we can pay for it, we can see how we can't continue to pay for what we're paying for now. It's just not sustainable. And so I want to acknowledge Steve Cicchini, who is here, I think, in this town hall, who did a lot of this analysis, and just to put it into context, but looking at some of our federal, state, and local tax expenditures on private health coverage and what we could do so much better with that money. So I'm going to share my screen and just share a few charts that I think tell this story most powerfully. So I hope everyone can see the PowerPoint here. So let's start with the federal level. And this goes back to, we heard from Julia all of the deadly impacts of the failure of our healthcare system in the COVID pandemic and how people's lives were lost and affected. While all that was happening, our private health insurers made record profits. They made record profits in 2020 because this industry is fundamentally based on taking in more money than they pay out. So they pay out when we use healthcare. And so when people weren't using healthcare, they were making in record profits. And I don't know what the latest information is, but a survey done was showing that more than half of our physician practices were going to have to close their doors, or were laying off people because they weren't getting this revenue, they weren't getting their income. So money was not going to care, it was going to profits. And if you look at the biggest margins that the private insurers were getting in 2020, it was through their engagement in the public programs. So Medicare Advantage and the Medicaid managed care, our tax dollars were going to give huge profits to these insurers who were able to keep money instead of having it go to healthcare. So that was the first really, I think, very astounding piece of information that I thought really helps us think about why now. This system is fundamentally not about providing for healthcare needs, it's about making profits for shareholders. And that was exposed by the pandemic, I think, more than any other time. Now, some of that excess profit will have to come back to us in the form of rebates because of the Affordable Care Act provision, but the insurance companies have 3 years to figure out how much they owe us back. So I'm not convinced we're going to see all of that. So let's look at New York State. And if you look at the budgets, and this is a lot of analysis, this particular analysis was done by Darius Shanfar, the treasurer of Albany, and he shared this at a previous town hall, that if you look at the budgets of the amount of money that is being spent to provide private insurance coverage for the county employees or the city, Albany city employees, compared to what they would be paying for that coverage, but much better coverage under the New York Health Act. So their payroll tax contribution is the blue bar. What they're currently paying now for private coverage is the orange bar. And the really big one for Albany County includes the county's Medicaid share. So if all of that expenditure goes away, that budget could save 83% in Albany School District, 84% in Albany City, 95% less money going to pay for health coverage under the New York Health Act. That's our tax dollars, their tax dollars in Albany. And if we look at Suffolk County, where I'm based, and this is the analysis that Steve did, looking at the current property tax revenue that they take in is the bar on the far left, and it's over 700 million. If you look at what portion of that, the next bar is how much our county is paying for private health insurance coverage for county employees, for our police officers and others. It is 68% of our property tax revenue. Now, of course, the county gets other sources of revenue. It's not that 68% of the entire revenue, but it's 68% of our property taxes that we pay in. And if the New York Health Act were in place, the county would pay a fraction of that. There would be almost $800 per household less going to pay for health coverage, and what would be much better health coverage. And what we're seeing, if you look at the county's budget for 2021, you're seeing their projected healthcare costs are only going to continue to increase. So where does that money come from? They're going to have to either continue to raise our taxes to pay for this waste, or they're going to have to erode the coverage of the county employees. And in fact, this year is the first year that county employees had to pay anything out of pocket at all and have deductibles added to their health coverage. And that will continue. And I think that was what Andre mentioned. This starts to happen with the unions. There's only so far you can go until that coverage starts to have to erode. It's just not sustainable. And then finally, this is also brought down to the level of the school districts. And this is an analysis that Steve did for Huntington School District, looking at what they're paying to cover teachers and other school employees. I don't even think retirees are included in this one. But if they were to cover all of the employees of the school district through the New York Health Act, they would save 75%, a 75% cost reduction. That could be money that goes back into our schools and providing all of the additional resources that the schools desperately need. So I'll stop sharing now. Those are just some, I think, what I found to be very astounding quantification of the waste and shoveling money from taxpayers, from people who need care into the profits of the private insurers. And that's just one way how we would pay for this, in addition to the broader efficiencies that we would save that Naomi shared in terms of these ridiculous administrative costs in our system, which go up to 34% of total expenditures in some estimates. And then there's a third way that we would pay for it that I don't think we talk about enough. And that is a single payer can use our healthcare system like a strategic public asset, and to actually change the way that money flows through the system, can change the kinds of services that are emphasized, that get paid more. People are worried, are our hospitals going to get paid less? Will the doctors get paid less? And I think some of them probably will get paid less, and they should. they're not necessarily providing the life-saving necessary services. So a lot of these services that are the most lucrative, but maybe our primary care doctors would get paid a lot more. And that single payer ability to manage the resources in the system and to send it to where it can do the most good to the populations, to the locations, to the services is another way. Not only can we save money, I think, but also can provide better care and really improve the equity of our system. Thank you.
Thanks, Cheryl. And thanks again to all our presenters for a really interesting range of perspectives on this moment that we're organizing in. We have a time for a few questions. So if anybody wants to address a question to any of our speakers, and you can type it in the chat, we can take a few minutes for that. And then we're going to head into our breakouts. And there's a little bit of a change of plan in how we're doing that. We're going to offer you the choice of the 5 different breakouts we're running. We'll go over that after the Q&A. But yeah, any questions anyone has, now's the time.
Actually, I have a question for Cheryl. Do you know the school district information? Is that just available? Are there just certain school districts that data has been made available for? And like for the city employees savings and stuff, I mean, it's like really striking information. I would imagine that like every municipality probably stands to save a lot of money. Where is that coming from? And like, is there a way to get that data to those people?
Thank you for that, Naomi. And that's actually a question for Steve, Steve Tacchini, who did all of this analysis. And a lot of these budgets are public. And I know that Darius Chanfar, the treasurer in Albany, said, that information there is sometimes a little bit difficult to piece together, to pull out where these costs live in the budget, and there might be a little bit of extra work there. He has put together some guidance for how anyone could do that. So as long as you can access the budget to how to go through and put together the healthcare costs. But I don't know if Steve wants to weigh in on the chat how to access some of these other budgets.
Yeah, hi, could I weigh in real quick?
Thanks, Steve.
So the payroll data comes from a website called See Through New York. You can download the payroll data for any school district there. And then the estimate for what it would cost the school district to pay the tax for the New York Health Act comes from using the RAND analysis or Len Rodberg's analysis, whichever one you prefer. They come out within a few percentage points of each other. And the data for, what the healthcare costs are now in the school district comes from their budgets. You just go online and search their budgets. That's it. Just spending the time to do it.
So we have a couple questions in the chat now. The first one is for Andre from Earl. Earl, do you wanna ask your question?
Earl, I think you're muted.
Yeah, okay. I finally figured it out. I'm on my phone and I don't use it for Zoom calls too frequently. But anyway, Andre, so we heard from another union person like a month ago or something, and he was mentioning some of the civic or city unions in New York that they feel that their membership will actually end up paying more under the Single Payer Health Act. And even though he was in favor of the Health Act and everything like that, and thinks that in the long run it's necessary due to all the rising costs and it'll be a savings, but in the short term, he had a feeling that there would be opposition among membership in various unions that to that. Do you know anything about that, and how it's progressing in different unions? And yeah.
Sure, yeah. Well, it's tough for me to speak on public New York City unions, I'm in a private sector union in Buffalo, which is the second largest city, but is about a 20th the size of New York City. So it's harder to know exactly how the economics work for them, but I can definitely speak from my own perspective and from other building trades union perspectives. First, my non-cynical answer would be I don't see how it's plausible that it would cost more money. I mean, I laid the numbers out. It cost over $70 per day to insure every member in our union. That's if they're working 8-hour days, which this is construction. When we're busy, we're working 10 to 12-hour days, 6 days a week. So our healthcare is extraordinarily expensive right now and will become, I mean, there were some very excellent graphics put together there by Cheryl and Naomi that show it's not, I don't understand how that can be the case. My more cynical answer, taking off my union hat, because I can say that this is not the case with the other officers here, but in my union, but I do believe a lot of people in union leadership have a political bend that favors, there's in the mainstream Democratic Party, there is a way, there is a belief that we can get to universal coverage without without the government being the single payer. And I do believe that there is just not necessarily an evil or a bad will, but there's, if you follow the money, I think it is reasonable to say that the mainstream Democratic Party does tend to work hand in hand with unions. And I think a lot of officers tend to just take the words that they hear from politicians at their face value. I don't want to say that's definitely the case, but I don't think if you do any realistic assessment of the New York Health Act or of Medicare for All, you can come to a conclusion that it winds up costing more money than what we currently have, which is the most expensive healthcare system in the world, bar none and by far. So I just think that they're misinformed.
Thanks, Andre.
And we have another question from Sandy in the chat about perceptions of the New York Health Act's viability. Sandy, do you want to ask your question?
Yeah, so it seems really encouraging that there are all these co-sponsors for the New York Health Act, but it still seems like when I ask people, it seems like most people think it's not going to pass anyway. And what's even worse is that a lot of people I talk to just, on the street, they're not even aware of this. So it seems like, it's not really in the media very often that this is going on. And maybe we just need to get that out there more, because I think people would be excited if they knew this was an option and they thought it had a chance to pass. And maybe that would help to get some more momentum behind the politicians. So I guess I'm just wondering, why is this perception, despite all these co-sponsors, that it's not going to pass? And, are you guys doing a lot of media efforts to try to get the word out that this is a possibility?
So if any panelists interested in taking this one on, go ahead. And anyone from the working group as well who's interested in speaking to this could be good as well.
I'll say real quick, I do think I think in regards to that, that's sort of what we need to do moving forward, right? That's kind of our role, I think, as DSA, is to get public engagement out there. Because I agree with you, Sandy, that if people were aware of this, because it doesn't show up anywhere in the news. I can't find anything about it. I know I read a long time ago that Governor Cuomo, when he didn't have to work, when he had the IDC, the Independent Democratic Conference that helped keep the Republicans in charge, he had no problem saying on occasion that he would sign the New York Health Act if it crossed his desk. And now mum is the word, because the actual political will is there. So I think if we, stir up enough people, that's sort of our role, and to find other leftist organizations to help us do that. I think that is kind of, that's our role, to get people involved.
And just get on news segments like New York One and various other local news and have them start doing stories on this.
Yeah, I mean, there's ways to reach people without having to go through the major press that we're all aware of. And like you said, yeah, like local news, I think that's a huge way to do it, and social media and elsewhere. But that's what we're here to figure out, right?
Okay, thank you.
Okay, so that's about all the time we have for questions. And we're going to move into our breakouts. So Carissa, who is very generously running our Zoom, is going to give everyone the choice of 5 breakouts. I'm going to type in the chat which one is which. And please go to the breakout that you are most interested in. And we want to especially encourage people to attend our canvassing and phone banking breakouts, because this is really going to be the heart of our campaign. So just a second here.